Thank you very much, first of all, for the invitation. It's quite an honor to talk to this group and to tell you some of the things that I've been thinking about for the last period of time. We talk about diversity, and diversity is one of those things we have to remember. We spend the majority of our life being an adult, and yet adults are rarely diagnosed with an immune deficiency. And that's curious because, in fact, our patients not only get older, but in fact, something we have to incorporate is that many of our adult patients actually do have an immune deficiency. And in fact, it's genetic. And in fact, they can be any age whatsoever. They can be 20 to 100. And my oldest patient with a gene defect is 75 years old. And now I realize what her problem has been this entire portion of her life. Now, when you're talking about common variable immune deficiency, first of all, let's talk about what we're talking here. And that's going to be, we're just really honing in on the B cell. What B cells are capable of is amazing. 20% of your serum protein is immunoglobulin, and those antibody-making cells are living as long as perhaps in many cases you do. In other words, the plasma cells that you formed as an infant are largely present currently. That's not true for all of them, but that's true for many of the long-lived plasma cells. It's an incredible master act of producing immunoglobulin over this long period of time. And so there's many things, actually, when you think about it, that could go wrong, starting from the very beginning and working to the end. When I look at a slide like this, it looks so simple, doesn't it? You just simply hop on stem cell and slowly you get enough information from your surroundings. You migrate through a lymph node, you get educated by an antigen, and first thing you know, you're a plasma cell. And actually, of course, there's many things that can go wrong. And of course, we know the names of many of these: the A-gamma globulinemia, the hyper-IgM syndrome, antibody deficiency, IgA deficiency, which still, by the way, is an unknown proposition. And then common variable immune deficiency has this kind of awkward name, which we're a little bit uncomfortable with because it sounds so completely nonspecific, doesn't it? It doesn't really help very much. But if you look at it in clinical practice, and this happens to be the data from Mount Sinai, it's somewhere around 1,000 patients that I've seen over a period of time, the great majority of them actually have an antibody problem, and in particular, common variable immune deficiency. IgA deficiency is number 2, IgG subclass is number 3, X-linked A-gamma globulinemia is number 4. And moving around the line, you can see that about 50% of all the immune defects that you will see in clinical practice have something to do with the way that antibodies are made. Now, I'm going to admit that I do see a lot of common variable immune deficiency. On the other hand, this is the same as every major textbook. Dick Steam's textbook, which was taken over by Kate Sullivan last year, this is the same picture that we all have when you look at what the patient has in the practice office. So take a look at the common variable definition, which again is incredibly loose, I admit it. It's very nonspecific. You just have to have a low IgG and an IgA and or IgM. You have to prove that the antibodies are not useful. You immunize and then again show the same thing, that antibodies are not made. And the next thing is you really have to be not really an infant anymore in case there's really another defect. That particular rubric is only on there so that you don't stop thinking about it and you don't decide that person is immune deficient until a little bit more time has gone by. And then, of course, you have to prove that the antibodies are not made. And then you have to go and think again, like, is there something else that's going on? Could it be protein loss in the GI tract? Could it be a leukemia? Could it be a lymphoma? Could there be any other reason why this gamma globulin level is low? So how common is it? The honest truth is that we don't know. Textbooks, the highest textbook number that I've been able to really find is somewhere around 20,000. Many say 1 in 50,000. Honestly, I think a better guess is 1 in 10,000. And if so, that means there's somewhere just short of 4,000 CVID patients in Morocco currently. And I think this is another one of those curious slides, because now we're going to talk about the things that we don't understand. I don't understand this, and I think it's one of the reasons that patients are not diagnosed either, which is that for some reason, the age at diagnosis is generally in the adult period. In other words, most people are between 20 and say 40 years old. Why is that? We're talking about a genetic disease, but why don't you know about it in the beginning? Why don't you know about it when the person is 5 or 10 years old? And that's one of the things that we have to just take into consideration when we're thinking about the genetics. Males tend to get diagnosed a little bit earlier, as you can see, but yet there's many of them that are diagnosed, as you can see. One of my males was diagnosed when he's in his 70s. And you're trying to think, does that really make sense for a person to be diagnosed with what we consider to be a genetic disease at that age? It seems very improbable, doesn't it? And I think that's one of our problems, because it really is a difficulty. But the other thing to remember is that it takes a long time for the diagnosis to be made. In other words, most patients will tell you, oh yeah, right, I did have that pneumonia when I was 10. Oh yes, right, I missed a lot of school when I was 20. And going through college, oh right, I had another pneumonia. Or I had, for example, ITP when I was 5 years old. And for me, those are little hallmarks that say, yes, but that means to me that you actually had an immune deficiency in those years and we did not know it. So we know that this is the 7 to 8 years after the first characteristic medical event. And what is characteristic is, again, rather debatable, because we could say it was the ITP, or we could say it was that first time they had a pneumonia. But many patients don't have that. What they have is a little bit of continuous sinusitis, for example, a little bit too much gastrointestinal disease, in other words, diarrhea. Autoimmunity is, again, the number 2 for us, gastrointestinal problems. Some of them have also been diagnosed with cancer. This is the usual medical history. And moving down the list, you can see there's a number of things. I mean, some of these patients on this particular list also had a splenectomy previously. And you have to ask yourself, yet they were not diagnosed at the time that they had a splenectomy? What was the excuse for that? Was it that they had a cytopenia and somebody decided that was the better treatment? Most likely that was the case. Now, these are the infections, and as you can see, sinusitis, well, sinusitis is very common. Are we going to test everybody with sinusitis? I doubt it. Pneumonia, not as common. Bronchitis, otitis, and looking down the list. Shingles is relatively common in patients with common variable because they don't make antibodies to the chickenpox virus at any time, and therefore shingles at a young age is reasonably common. And moving down the list, you can see other issues too. I'm just going to tell you about a few cases, and this is one of them. So this is a 28-year-old woman who, as you can see, her gamma globulin levels, I know that your scale is different, but you and I would both agree, there's no gamma globulin in this girl's blood. That's basically nothing. And she is a smoker. And so people think, okay, well, you know, you're a smoker, you can cough. But the first time any chest x-ray was taken, it showed, and CT in this case was taken, you can see she actually has rather severe bronchiectasis on this one occasion. The capsulated bacteria are the common cause, and that, of course, she's had that. She has not had pneumonia, and her cough was attributed to her smoking now all these years, the last 15 years or so, because she has been smoking for about the last 10 years. Obviously way too early. On the other hand, that doesn't give you no gamma globulin either. And so she is actually a patient with common variable immune deficiency. And as a matter of fact, she is no longer alive. And so she died of respiratory failure before the age of 30. So that was a misdiagnosis, actually, blamed on something else, blamed on her smoking in this case. This one is harder to understand, and I have to tell you, I've thought about this man many, many, many times. He's now 65 years old, and I've seen him every year since that time I first saw him. At the time, he's a 40-year-old lawyer, previously healthy, second episode of pneumonia in 2 years. And this, of course, is a massive empyema. The bacteria was Strep pneumoniae. Someone, I don't know who, measured his immunoglobulins, and as you can see, that is nothing. There is no gamma globulin in this man, and you think, but he's 40. How did he do that? How can you be 40 and be gamma globulin-emic? He has B cells, they just don't work. And this is the other reason that it's very hard for us to really incorporate this information, partly because it seems so completely unreasonable. How could you be 40 and be gamma globulin-emic, and yet he is? Now, I don't have a genetic reason for him. Obviously, we've been looking for the last, 25 years or so. I don't know his genetics. We haven't located one, but I'm sure there is one. And in his case, it's unclear. When did his B cells stop working? I don't know. But this is still common variable immune deficiency, and he's 40. And so that's one of the things that I think is hard to incorporate, is that it's unreasonable as an internist. It's very unreasonable. Now talk about unreasonable, these are unreasonable facts as well, which is that when you take a look at the patients who have common variable immune deficiency, you are going to put them on gamma globulin. They're all in immunoglobulin. You give them very good doses. They're going to have a normal amount in their blood. If you can possibly manage it, you may give them antibiotics when they require it. But some of the patients just don't do very well. And so that's sort of the topic that we want to now turn to, which is why do some patients, you think you're doing your best job, and yet some of them have complications. Now, Helen Chappell pointed this out first with the ESID data, and I think everyone is familiar with her paper in Blood in 2008. We did the same thing with our data at Mount Sinai around some of the 430 patients or so. And as you can see, that you can divide the patients into the two groups. Those who just have infections and they do beautifully, their survival is going to be the same as their next door neighbor of the same age. And yet some of them are going to have 11 times the mortality and the morbidity of that other group. And so this is where we spend a lot of time now, thinking, we're giving you gamma globulin, why are we not doing a better job? What's going on? So when you have about 700 of the CVID patients and you divide them into the groups, for me, about 68% of the patients that I see, since I really see those who have more of the complications, are likely to have some of these inflammatory issues. Infection only is a certain group, and that's the 32%, and then moving on to the other side of that pie chart, you can see that autoimmunity is number 1. Chronic lung disease is number 2, and lymphoid hyperplasia, splenomegaly, and so forth moving around that particular pie. So there's a lot of other things that somehow gamma globulin is not addressing. And that's where it's been taking a lot of time to say, okay, what do we not know? Clearly there's inflammatory pathways that are open, but why and what are they? And so many people have spent a lot of time looking for clinical markers, of course, genetic markers, laboratory markers. We spent a lot of time doing that, and I don't think we're home yet. We're not finished. On the other hand, we're a little further along the line. Now, talking about autoimmunity and breaking that open up for the moment, what is the main thing? Patients will commonly tell you, oh yes, right, I had ITP when I was 10. For me, anyone who has had ITP at any time, I would be very interested in knowing their quantitative immunoglobulins on that occasion. It could be they're normal. Okay, that's fine. Evans syndrome would be hemolytic anemia and or ITP. Number 3 is hemolytic anemia. For us, rheumatoid arthritis is number 4. And looking down the list, there's others as well. But 56% of the patients have actually had that history, either once or twice or 3 times, repetitive bouts of autoimmunity. It's a very, very common phenomenon. These are patients of mine who are all adults at this time, a couple of males and a female, absolutely very, very terrible levels of gamma globulin in their blood. And as you can see, the spleen is quite massive. So these are patients that have escaped having a splenectomy at any particular time. By the way, I'm not very keen on splenectomies in general, although I think 50 of my patients don't have a spleen anymore. These are ones that managed to escape. So having hepatomegaly and splenomegaly is a very, very common historical issue. Having this interstitial lung disease is very severe. This, of course, is one of those things that actually causes the patient to not survive. And again, these patients are all getting gamma globulin. So what am I failing at? I'm not doing a wonderful job here. How can you have all the inflammation, the lymphoid infiltrates, and granulomatous changes and fibrosis when you think that you're doing the perfect job and you are combating bacteria? Again, it's that issue of the inflammation that we don't understand. And that brings up a particular situation here. This is a 46-year-old, he's a church minister in New York on the west side, and at the age 27 he had pericarditis. And then he had some dyspnea, he had normal chest x-ray, he had a bronchoscopy, he had a biopsy. Somebody said, oh gosh, you have granuloma. And now this is sarcoidosis, that's what you have. Treated with steroids at the age of 36, he had a conjunctival biopsy. Again, there was some granuloma. Well, that happens in sarcoid. Yes, that can occur. The age of 42, cellulitis complicated by staphylococcal bacteremia. And then he had a very bad pneumonia at the age of 46, hospitalized, was quite serious, came to our hospital for second opinion. And what do you think? Well, he actually has common variable immune deficiency with no antibody to any of the things that you can see on this slide. So it's the wrong diagnosis, and it's been shown. I think the first person who ever wrote an article about this was Mary Beth Fasano, previous president of Quad AI, who wrote an article when she was a fellow saying that if you have sarcoid, you're diagnosed with sarcoid, you may wait 20 years to get the right diagnosis. So it's just important to realize sarcoid just simply means you were short on enough immunity to fight that infection. And the B team had to be called into action. The B team, being macrophages and monocytes, were given the job, and they're not very good at it. And so for that means that you have granuloma instead of fighting it with antibody or T cells. So he has common variable, and now he's on immunoglobulin, and he's doing very well. Now, the systemic granulomatous disease may be in the lungs, it may be in the skin, it may be the bone marrow, it may be a large abdominal granuloma, it may be in the spleen, as you can see. These are all patients of mine who have granulomatous disease. It runs about 10% to 12% of the hypogammaglobulinic patients, depending on whether they've ever had a biopsy. So for me, anyone that's diagnosed with sarcoid, I'm thinking that's a box that needs to be opened, because I'm not sure that that's really the case until I know that the antibodies are good. Gastrointestinal problems are another major issue for us. I will have to admit that we see a lot of gastrointestinal disease, partly because Crohn's disease effectively was invented at Mount Sinai. Burl Crohn was the chair of gastroenterology, so we do see a lot of Crohn's disease. On the other hand, now we see a lot of Crohn's disease that looks like Crohn's disease, but in fact, it's the immune deficiency talking. Now, not everything, of course, is going to be inflammatory. Of course, you can see on the top of this slide, there may be bacteria, there may be viruses, and of course, there may be other infections and just simply nodular hyperplasia, as you can see by the one in the middle there. That was a patient who lives in Michigan who lost around 100 pounds because he simply had no absorptive surface. And so these are some of the inflammatory things, again, that we don't understand that the immune system is trying to cope with. It's called Crohn's disease commonly, but in fact, it's really common variable immune deficiency, its manifestation. We don't understand this ailment either, nodular regenerative hyperplasia. It leads to portal hypertension, over time thrombocytopenia, and of course lymphopenia, and of course a large spleen, and in many cases it's really not reversible. We don't understand it. Let's just call it as it is. It's an idiopathic ailment that is waiting for us to decide what it's all about. We've had 45 lymphomas in 647 of our patients, which were reported in the European Journal of Hematology last year. Many of them are going to be lymphomas, or the commonest form of a cancer that the patient will get. Females are actually much more at risk than males are, as you can see. The age at lymphoma could be any age at all, between 11 and 81, and in this case, 26 have died. I will tell you one tiny thing, which is if you look at this paper, you'll see that we also had 6 other patients referred to us with lymphoma that on careful examination at the National Cancer Institute, it was not lymphoma. And so being very, very cautious about the diagnosis of lymphoma using an expert is very important, because those 6 patients had had chemotherapy, even though it was not lymphoma. It was just lymphoid hyperplasia instead. Now, these are my data, but if you go back and you say, Charlotte, that's one thing, that's Mount Sinai, what about the big picture? And this is the big picture. This is the ESID registry here. And these are causes of morbidity and mortality, lymphoma being number 1, tumors as well, granulomatous lung disease, splenomegaly, and moving down the list. So this is a very beautiful paper written together just to say what are the morbidity and mortality in a very open-ended way. So what's wrong with those B cells anyway? Why can't they do it? Why can't they make their gamma globulin? And first of all, of course, you could have no B cells. That's starting place. You could have no activation. You could have no maturation. You could not make a plasma cell, or you could make a plasma cell that doesn't know how to make a gamma globulin. So all of these things could go wrong. And we spent a lot of time thinking about the genetics. And this is a paper that I put together along with my wonderful colleagues, Leonard Hammerstrom and Hassan Ulbasani, who take some data from Tehran. So our Mount Sinai cohort at this time was 235 patients, and 31 of them had relevant mutations. In the Swedish cohort, 36 had relevant mutations, and in the Iranian cohort, 54% had relevant mutations. Now, everyone is called common variable immune deficiency, and yet There's 56 genes here. So 56 genes somehow could go wrong, and they're not the same in any of these populations. It's 56 in total. I've tried to give the coloration some of the same, but they were different in each cohort as well. So there's so many ways in which a B cell could make a mistake. And I think that's the other reason that it's taken us so long to get the genetics of common variable organized. It's because there's so many mistakes that it can occur from the starting place to the end. And that to me just strikes me as very, very interesting, just the number of ailments. Now, curiously, from the IUIS point of view, I am working on the B cell table, but most of these genes are not on the B cell table. And so they're not intrinsically B cell diseases. They're not intrinsically B cell genes. They're actually present in many of the other genetic locations, as you'll see on that table. The table is great. On the other hand, the B cell genes decided to migrate into every other portion of the chart. I find that very interesting. And this is a slide I put together using the backbone of Edwards et al. In other words, this is the areas in which the genes failed. Now, everyone here has B cells. They're not a-gamma globulonemic, and they have some B cells. It's just the B cells cannot finish that job. And the place that they fail is basically anything along this entire pathway, starting from the stem cell stage, working all the way over to that final plasma cell that simply cannot mature. And again, I find that such an interesting thing to tell us, because these are the ways that B cells work all the time. This isn't just our patients. This is how we do it. This is how a human makes a vaccine response, using every one of these genes. So questions. Why does it go unrecognized in clinical medicine? Why do so many patients have inflammation? And what are the genetic defects? Because we're 30% in, that's great. What about the other 70%? And what are the biomarkers that tell you the day the patient walks into your door, this is going to be a problem? What are the biomarkers that we can do? And then, of course, the biggest question of all, that's great. What can we do to safely treat these patients? And I think these questions are the ones that are giving us so many publications, because there's so many people working on this topic of how do you make a B cell? How does that B cell work? How do you make a vaccine response? And in a way, I think the common variable immune deficient patients are teaching us exactly that. And I find that really incredibly fascinating myself. Now, these are my wonderful collaborators at Mount Sinai, Stanford University, Rockefeller, University of Michigan, and of course the Karolinska Institute. Thank you very much for your inviting me to talk.